Acute bronchitis. Acute bronchitis is an inflammation of the bronchi, most commonly caused by a viral lower respiratory tract infection. It results in airway edema, increased mucus production, and a persistent cough, often with sputum. Peak incidence. Acute bronchitis is most common in children under the age of 5 and adults over 65 years old. Pathophysiology. Viral infection causes inflammation of the bronchial epithelium, leading to mucosal edema, hypersecretion, and temporary airflow obstruction. The condition is self-limiting in most cases and does not usually require antibiotic treatment. Symptoms: cough, productive or dry, low-grade fever, malaise and fatigue, rhinorrhea, and chest discomfort or mild pain. Signs: wheeze or rhonchi on auscultation, usually no focal chest signs, for example crepitations or bronchial breathing. Diagnosis. Diagnosis is primarily clinical. Additional investigations may be considered in specific contexts. Investigations: pulse oximetry to assess for hypoxia in high-risk patients. C-reactive protein, CRP. This can support antibiotic prescribing decisions if lower respiratory tract infection is suspected and pneumonia is not confirmed. CRP-guided antibiotic prescribing. CRP less than 20 do not offer antibiotics. CRP 20 to 100 consider delayed antibiotic prescription. CRP over 100 offer immediate antibiotic treatment. Chest X-ray. Consider if suspected community-acquired pneumonia, concern for underlying lung malignancy or other structural pathology, and if clinical uncertainty persists. Differentiating acute bronchitis from pneumonia. Both are lower respiratory tract infections but require different management. Key distinguishing features include acute bronchitis history, cough plus or minus sputum, wheeze, mild chest pain, and mild systemic symptoms. Community-acquired pneumonia history, cough, dyspnea, pleuritic chest pain, fever, chills, sweating, myalgia, and fatigue. Acute bronchitis examination, wheeze, and generally well appearing. Community-acquired pneumonia examination, fever, tachypnea, tachycardia, focal signs such as crepitations, and confusion in the elderly. Acute bronchitis chest X-ray, typically normal. Community-acquired pneumonia chest X-ray. This shows a new infiltrate, which is a consolidation. Complications: rare. Progression to pneumonia, especially in high-risk groups. Post-viral cough, which may persist for several weeks. And exacerbation of underlying disease, for example COPD and asthma. Management. Acute bronchitis is self-limiting, usually resolving within 3 to 4 weeks. Supportive care. Simple analgesia, for example paracetamol or ibuprofen. Adequate fluid intake, rest, and smoking cessation advice if relevant. Antibiotics. Routine use is not recommended. Consider only if CRP guided thresholds are met or the patient is at an increased risk of complications, including number 1, underlying chronic heart, liver, lung, kidney, or neuromuscular disease. 2. Immunosuppression, for example, chemotherapy, HIV, steroid use. 3. Cystic fibrosis. And 4. Age-related risk. So if age is over 65 with 2 or more of the following: diabetes mellitus, type 1 or type 2, history of congestive heart failure, current use of oral corticosteroids, and hospital admission within the previous year. If the patient is aged over 80 years old, then only 1 or more of these features need to be present. First-line antibiotic options, if indicated. Doxycycline, which is not recommended in pregnancy. Alternative first-line medications are amoxicillin, clarithromycin, or erythromycin, depending on the allergy status and suitability. That was the full video, and there's hundreds more like it waiting for you at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today